Go ahead.
Okay, so this is a 45-year-old lady who presents to us with a 5 days history of high-grade fever and deeply yellowing of her skin.
Ooh, incredible. You've set up Shema for a wonderful chief concern. All right, Shema, take it away. Thank you, Aisha.
So starting with the chief complaint of yellowing of skin, I started thinking of jaundice. And so we have a kind of a hyperbilirubinemia. And the key question is it indirect or direct? And as we know, we can always divide it into pre or intra or post-hepatic causes. So it's still open. And then talking about migraine. Like 5 days of migraine, it's still possible. I learned like if we don't cross over 1 week, but the essential question is also having like migraine, fever, yellowing of skin. I would be quite interested something about what's her background. Is she like pregnant or anything like this? Because as we know, I'm currently in the OB gyn. That's why I'm thinking of something like a pregnancy related hepatitis or anything like this. Yeah. And before talking too much, I would lead the way to Robbie.
I think it's literally impossible for you to talk too much, my friend. You know, it's very easy to pay attention to how an astute clinician like yourself, where you choose to start. And you chose to start with the jaundice because I think it's the most specific part of this case. You know that you will walk away from this case explaining that jaundice. And the only way that it's not a definitive, it's the only way it's not a fundamental part of this case is if it signifies Gilbert syndrome, which is basically the liver going unnecessarily crazy in response to a distant disease process by which the jaundice is just a distractor. But the reason that's not at play is Gilbert's rarely causes a bilirubin above 5, which you would expect to be higher in this case based on the depth of the yellowing of the skin. So you'd say, hey, Gilbert could distract me, but the amount of jaundice here seems more than 5, which would be in excess of Gilbert, so I know the jaundice is going to be explained. And if you're going to make a bet here, you should probably bet on direct hyperbilirubinemia. The reason for that is that most patients who have hemolysis significant enough to cause indirect hyperbilirubinemia often have shortness of breath as a result of symptomatic anemia. So the lack of shortness of breath in a patient who is this jaundiced should help you prioritize direct causes. So Shema, when we're in the world of fever plus direct hyperbilirubinemia, what are your reflex thoughts?
What I learned, like fever, jaundice, always rule out something like a cholangitis. Yeah, that's one thing I'm very concerned of. And otherwise, generally, like 5-day time course makes me think like if you have acute inflammation, the fever makes me concerned about kind of an infection, because as we learned, acute inflammation equals infection.
It's superb. I don't know if you caught that, but basically the entire CP Solvers team who has their video on is like kind of gently, beamingly smile every time you talk. It's really endearing to see. Another subtle sign that you're absolutely crushing it. All right. They're doing it again now, by the way. Aisha, do you want to give us more?
Yes, absolutely. Okay, so on exam, so the vitals are stable. She's deeply, deeply jaundiced. There's no flap, no bruises, no excoriation marks. The rest of the systemic examination is essentially unremarkable, and I would like to comment on the abdominal exam. There is no hepatomegaly, there's no tenderness in the right upper quadrant, and the systemic review as well is essentially unremarkable. So two really pertinent findings were that despite being so deeply jaundiced, she was otherwise absolutely fine. I think I would like to give you some past medical history as well. So she has been getting admitted with us over the past 6 months, multiple times, with a severe drop in hemoglobin. And it always pointed towards hemolysis, but we were never able to find out why she was hemolyzing always. Ultimately, she was sent to another city with a really good hematology service, where they extensively investigated her and diagnosed her to have autoimmune hemolytic anemia, the cause of which was uncertain. And then they started her on mycophenolate, mofetil, on which she has been, so she has been taking that for the past 2 months. And apart from that, the drug history, so she's on low-dose steroids, about 10 milligrams of prednisolone daily. And so there's mycophenolate, and she's also on 400 milligrams of acyclovir daily for a CMV PCR that was positive with copies of around 500. So this is about 2 months back. This was her 2 months, like 2 months prior to this presentation. She was investigated in the center and started on this regimen. And she has been on follow-up with them for the past 2 months. And now this thing happened. So I think I should start here.
Aisha, you're keeping us on the edge of our seats. This is wow, so intriguing, and I'm already taking back some inferences I made earlier. But Shema, what are your thoughts?
So basically, talking about her recent medications, so especially the steroids, always make me think of having an immunocompromised state. Like as we know, there are several infections where you can catch something like yeast, like Candida. And also seeing that she's using acyclovir, we know always the nephrotoxic. There's this where we say start low and go slow when you use acyclovir, and then also seeing that she's CMV PCR positive. I mean, I don't know if can we say that this is acute? I mean, like, as we know, CMV is also a virus that is hepatotropic. As we know, these herpes viruses can affect the liver. This is also something that keeps me a little bit concerned. And also seeing the hemolysis, like that she has an autoimmune hemolytic anemia. So I'm asking myself whether there could be like two reasons for her jaundice. Could it be the hemolysis together with any intrahepatic cause? And also seeing that she doesn't have any sign of hepatomegaly and no tenderness, which shifts me rather not about any hepatobiliary cause, but rather maybe more intrahepatic or more into the direction of hemolysis, because she has a past medical history of it. And yeah, I would be very interested to see how her liver function tests are. Yeah.
I love it. You know, every astute discussant always ends their reflection by saying, "I would be interested in," and then outlining your next step. So you're already like hitting the fine points there. And my favorite thing about what you said is you said it doesn't have to be or. It doesn't have to be indirect hyperbilirubinemia or direct. It could be both. And the best example of that, it is seen not uncommonly worldwide, is a chronic hemolytic disorder resulting in pigmented stones causing liver disease. And that is not an uncommon complication of chronic hemolytic diseases like G6PD deficiency, like sickle cell anemia, and like hereditary spherocytosis. The latter of which deserves specific consideration, namely hereditary spherocytosis, in patients who have been diagnosed with autoimmune hemolytic anemia who don't follow the expected pathway. The reason that is both those conditions share the common denominator of spherocytes. And often if somebody with autoimmune hemolytic anemia goes in a pathway you don't expect them to, you should step back and say, wait, is this actually a different kind of spherocytic disorder? But I think that's the space we're in. This person was giving a working diagnosis and they haven't gotten fully better. And so the question is, do they have something completely unrelated, as you alluded to? Do they have a complication of the diagnosis? Autoimmune hemolytic anemia may flare by itself, but 50% of patients with IHA, autoimmune hemolytic anemia, have an underlying trigger, usually another autoimmune disease like lupus, but sometimes a lymphoproliferative disease like CLL or Hodgkin's lymphoma. So I think the real analysis here is first, let's try to figure out what the problem is today. Is it an indirect, or both? What is the status of the liver? What's the hemoglobin? And our hypotheses will have to then map onto the background of how strong was the diagnosis of autoimmune hemolytic anemia? Was it based on a Coombs test or just spherocytes? And if that ground is shaky, we have to analyze complications of autoimmune hemolytic anemia or mimics of autoimmune hemolytic anemia. All right, Aisha, back to you.
I was also asking myself,
Yeah.
talking about the autoimmune hemolytic anemia as a trigger. I mean, I always divide it between cold agglutinins and these warm. And for cold, as I know, I feel like mycoplasma or EBV can do it.
I think, oh, I thought I froze. Ha, no. Oh, you froze for like a second. You know, I think,
Ah, okay, I
yeah,
see.
we're live.
I'm live? Okay. Yes, I was
Yeah.
asking myself whether CMV could also trigger something like an autoimmune hemolytic anemia, because we know EBV or mycoplasma can do it with the cold agglutinins.
Beautiful. I couldn't agree more. I think it's a big question to ask. Is this autoimmune hemolytic anemia or not? And if it is, one common reason why it's not getting better is there's a trigger. And the trigger certainly can be infections like you mentioned, cancers and autoimmune diseases. And I think infections should probably be the first thing to think about. Yeah, I think that's awesome. Alrighty, Aisha, back to you.
So I'll give you the first set of labs that we got when she got admitted. So her CBC, the hemoglobin was 11.5 with an MCV of 100. The platelet count was 110,000. The white count was 29,000 with a neutrophilic predominance. The bilirubin, I know everybody wants to know the bilirubin, it was 29 with a direct of 26. And over the course of her stay, it increased to 35 with a direct of 32. The ALT was 800 initially, and then it rose to 1200. The INR was 1.4. The APTT was 32 seconds against 30, and the ALK force was around 300. The initial viral serologies that we got, considering that some of the things are endemic over here, the hepatitis B surface antigen and the core antibodies IgM were negative, and the HEV and HAV IgM antibodies were also negative. The ultrasound did not show any gallstones, any biliary dilatation, or any other such pathology. So the ultrasound of the right of the colon. And so we have sent a CMV PCR as well. That is awaited. We don't have that yet. Yes, so that's the situation so far. Is there anything else I should tell you about, or
Yeah.
is this?
Maybe Aisha, I can take a stab, since the very point of this VMR 30 minutes is to actually think fast like we do in acute care. And so I think I'll summarize. I think the data that you gave us was the patient has a marked neutrophilic leukocytosis, but actually an underwhelming hemoglobin, it's 11.5. And you told us that the patient has a marked severe direct hyperbilirubinemia with relatively preserved liver enzymes and a relatively preserved INR. And in summary, you told us that the hepatitis serologies are negative with CMV PCR pending. And I'm curious, Shema, with that summary, you're in a very tough diagnostic space here, and I'm curious what you make of it.
So I heard that the ALK force was also high. Am I right? Was it 300? I mean, I am still not. I mean, if the direct one is high, we are more prioritizing now any hepatobiliary issue. So is it intrahepatic or posthepatic? And I am quite more concerned, like about a cholestatic issue due to the elevation of the ALK force. And what I was also a bit thinking about was looking into the anemia. Like she has a high MCV, a kind of a macrocytic anemia. I mean, the only things that I associate with a macrocytic anemia are more like something like folate or B12 deficiency, or when it's someone like an alcoholic. But I think that this is not the case in here, right? And yeah, so I would be very, very concerned. I would be very happy to see some kind of imaging, because this will help us to, to see whether it's more within the liver or the hepatobiliary system. Yeah.
Absolutely superb, my friend. This is a very unusual combination of the data that you have. And I think you picked up on the bilirubin first as your localizing test, and I think that has been productive. So the bilirubin now is direct, and the question is it a problem in the liver or is it a post-hepatic problem? And the ultrasound is pretty good, but not perfect at saying that, hey, you might actually have something in the post-hepatic tree, like a cholangiocarcinoma or a big stone or pancreatic cancer that you will see on CT. But I would say the probability of an extrahepatic cause is low because the law of proportionality is broken. It's very unusual to have something so subtle that ultrasound misses it that causes a bilirubin of 35. If the bilirubin was 5, you might say, okay, something's a little small that you need a CT or MRCP or even ERCP, but 35? Very hard to believe. So I agree with you. This disease process lives in the liver. And whenever you're trying to understand a disease process that lives in the liver, the first question is the AST and ALT very high? And here, no. So like you said, this is a cholestatic intrahepatic liver disease. And there are not many of them that cause a bilirubin this high. And the truth is that if you see this in the United States and there's no infection, that there's no environmental infections at play, this is a classic laboratory description of alcoholic steatohepatitis. A patient with marked neutrophilia, marked disproportionate hyperbilirubinemia, and a macrocytosis. So here you would query the possibility of alcohol use and consider that, though in this instance, it's hard to imagine that the signs of chronic alcohol use were not apparent on vitals or exam. Patients who drink enough alcohol to get alcoholic steatohepatitis usually have signatures of that on their exam with facial rubor, telangiectasia, spiders, so on and so forth. And the patient would be cachectic. It's hard to imagine that no signature on the exam. The other big condition to reinforce, which is something you said again, which is acute fatty liver of pregnancy. It's notorious for causing liver enzymes this high, but the good news is it only occurs really in the 3rd trimester at a point where pregnancy would not be something, would be again apparent on exam if the patient was unaware. So what are you left with? You're not left with much except one important condition, which Laura taught us on VMR a long time ago. And that is what's called benign recurrent intrahepatic cholestasis, which is a familial condition that causes recurrent episodes, maybe misdiagnosis of IHA, of severe intrahepatic bilirubin elevations up to the 20s. That her patient that she presented a few months ago, maybe 6-7 months ago, had a bilirubin of 20, 25. But the big concern in those patients is they usually have a trigger to cause them to have a bilirubin this high. And I think the trigger lies in that white count. So I worry that she has an infection with that white count, but I'm wondering more and more, given how minimally symptomatic the patient is, that this cholestasis, despite its severity, is actually benign. And the reason I think that is because the number of bilirubin is so high that if it weren't anything but benign, I would expect the patient to be in the ICU by now. But yet her vitals are normal, her liver enzymes are normal, her INR is basically normal, her creatinine is normal, her hemoglobin is normal. So that's probably what I would be leaning towards. But I think there's a lot of other things to entertain, especially the no miss possibility of what you said earlier, which is cholangitis, and she has something subtle on CT that we don't see. After me blabbing that much and you having some time to think, do you have any additional thoughts that crept into your mind?
Well, this was basically poetry. I'm just a bit, I was thinking about, now here standing that the liver enzymes aren't normal. Would it actually change anything in the differential? Because I see that the ALT is now 800. Would it shift actually the differential of the benign intrahepatic cholestasis or not?
Yeah, sorry, I missed that. I didn't realize that the ALT was that high. I think it should. It certainly should. When the ALT being that high would push you to consider the things you mentioned, the acute viral hepatitis, the toxins, consider autoimmune hepatitis for sure. But I think no matter what the liver enzymes are, a bilirubin of 35 is so out of whack that I would probably pursue those hypotheses in parallel. Yeah. Yeah. So I'm trying to reformulate. I think what I would do is use the DDX of acute liver injury for sure and say, okay, is it a viral hepatitis? Is it a toxin? Is it autoimmune hemolytic anemia? Is it Wilson's in a patient who has a concomitant, in a patient who has a concomitant and poorly described hemolytic anemia, which Wilson's can do. But I think I'm still struck so much by how high the bili is. And that may be a distractor. It may just be a unique idiosyncrasy of this case, but I'd still consider it. Yeah, it makes alcohol unlikely though, that's for sure. Alcohol should cause the liver enzyme. Other thoughts, my friend, before they hand the mic to Aisha?
Because when we were thinking about alcohol, I always learned it like that AST is 2 times above ALT. I mean, is this necessary or is it just textbook reading?
No, I think it's very common. I think the textbook has helped you out in that specific setting. Alrighty, we'll give the mic to you, Aisha, to tell us where you're at with the case and what you've learned.
Yes, so really interesting discussion. The bilirubin has everybody stumped, believe me when I say this. The professor on rounds is totally, because it's really, so everything is getting better except the bilirubin. I think, Ravi, there was something about a delta bilirubin that takes some time to clear, and there was something like that I read some time back. Don't exactly remember it, but anyhow, so her liver enzymes, they were very elevated initially, and they're coming down. Initially I thought, okay, maybe this signifies that the liver injury is getting worse because she has no more hepatocytes left to give us the enzymes, but the INR and the albumin, they are still normal or not that bad. And so where we are at right now is we are waiting for the CMV PCR. We think that it might be possible that the CMV that was initially just, we were giving her the cyclovir for prophylaxis, that may have flared up because of the mycophenolate, and that may have caused an acute hepatitis like picture. So we are waiting for that PCR. If it comes out to be more than 2,000 copies, that may just have caused all of this mess. We have also started a 24-hour urinary copper collection for Wilson's because the IHA and then now the liver injury, this could very well be just Wilson's. And we have also, because she had this IHA that had predisposed her to repeated transfusions in the past, she has had a total of, I think, around about 30 transfusions in the past 1 year or one and a half year. And we were also thinking about secondary hemochromatosis in the sense that so many transfusions and this may well be coming out. So the autoimmune hemolytic anemia was well controlled on the mycophenolate until this thing happened. So we are currently working her up. She's not getting worse. That's a really good thing. And that's where we are at the moment. We are giving her some immunosuppressants and broad spectrum antibiotics and the like, just to keep her stable for now and to not allow the autoimmune hemolytic anemia to crop up again. But it's still an open case, and I would update the CP Solvers family as soon as we find an answer.
Oh my gosh, I'm just completely, yeah. I think every time Aisha's presented, literally 100% of the time, we're all just completely like, wait, what did you say about that number or that exam finding or that? Oh, thank you, Aisha. I hope you occasionally see a regular old UTI or some cellulitis once in a while. I hope, because I don't know if I'd be able to survive seeing cases as tricky as this one, but we're very grateful that you take the time to share them. Thank you. Shema, how did it feel?
Oh my God. I mean, having talked to you before that, it was quite relaxing, I have to say. I mean, sure, I'm still very excited, but to see that this is such a relaxing atmosphere, also having the back of the wonderful people here on the chat. So it was very nice. Thank you so much, guys. I learned also so much on the chat. You are all on fire.
You are just the kindest soul. I'm so glad you enjoyed it, Shema, and we all know this will not be the last time that you share your marvelous thoughts with us. Oh, a wedding tomorrow, but teaching points today. Franco, please take it.
I just realized Maria put the bachelor painting again. So this was a wonderful case. I really love hearing Ravi, Shema, and Aisha doing tackle down this mystery case. So for the teaching points, first we learned that jaundice as a center of gravity. We need to correlate with the levels of the probable levels of the bilirubin with the physical exam. Then we can deploy our schema about the filtering of jaundice, prioritizing direct versus indirect. But when we have some modifiers as fever plus jaundice, we can always take into account the base rate of disease, thinking about cholangitis versus other causes. Always keeping in mind the indirect versus direct modifiers. But sometimes indirect plus direct can result in a mixed pattern. For example, hemolysis can induce gallstones and then a mixed pattern. Autoimmune disease always comes with a bug. We have to think about triggers like infections, mutations, or overlaps with, among others, autoimmune disease. Direct bilirubin driving jaundice prioritize liver problem versus extrahepatic. Higher levels of bilirubin prioritize liver problem instead of extrahepatic. And finally, we have to take into account that sometimes there could be dissociations between bilirubin levels, the overall status of the patient, and the time course of disease. So for example, here with the autoimmune background, we can probably think about the trigger and that these higher levels of bilirubin is what the patient was kind of get used to over the time. But we will love to learn more of the case when we have a definite diagnosis.
So crisp and concise. I absolutely love it. Congratulations again on tomorrow, Franco, and thank you again, Shema, and the whole CB Solvers team for hanging out here. See you next time.